Okay, it's 5:40. Why don't we get started? The introduction will take a little while. That way some other folks can dial in. Good evening, Byron. I'm really honored to be moderating tonight's class. I'm the course director along with Dr. Jim Ebert, who is the best co-pilot and mentor you could have in the class. Dr. Ebert is the immediate past chairperson of the Department of Population and Public Health prior to his recent retirement. And of Oz, the lady to my left is behind the green curtain, and she's running all the technology. It's our super grad assistant, Leah Elliott. So she's making the whole thing work. I'm just reading the script. Tonight, you'll be students in the last class of the fall semester for Wright State's Department of Public Health Strategic Leadership in Healthcare. There'll be no tests and therefore no credits for any of you. Just a little level set. The students who normally take this particular course are the public health students who want to major in a leadership role, the MBA students from Wright State who want to have a concentration in healthcare, and it's the third course in 3 for the Executive Healthcare Certificate from Wright State. So that's the population that we normally have in this class. A really good group of folks. Since none of you, well, some of you are some of our guest lecturers, I thought I'd just take a second and run through and show you what the course looks like. So this is what the class looks like this semester, and we've done really well with this course because we rely very heavily on operational guest leaders to come in and facilitate conversations. They really don't come in and lecture. They come in and lead meaningful conversation about how things I call really work. If you look up there, we have a class on culture organizations. Michelle Wilson, Director of Primary Care Network South for Premier, leads that. We have a session on high-performing teams. Kim McGregor, who's now the Chief Operating Officer of Miss Medicine, leads that. Planning number 1, Nick there comes in and tells us how to build a plan, followed by Mickey Clancy from Premier, who comes in and shows how to monitor the plan. Marianne Weber works for App Architecture. It's one of the more unique classes where students actually learn how to build things like 11 stories tower at Miami Valley Hospital. Public health communication. Bill Wharton, who used to be the public relations guy at Montgomery Public Health, comes in and does a really intriguing conversation with the students, teaching them how to respond to communication and make sure they get their main 3 points done in 27 words or less going through that thing, gives them tips on how to dress and how not to dress and those kind of things, and walks them through scenarios on how you answer questions in tough situations. The next class we label it human resources, but Dave Holman, who's a general partner and vice president at Bogo and Brake Vendor, comes in and talks about under human resources. He talks about the health benefit planning piece, and he does a really neat section on helping our students understand how drugs are so marked up and don't need to cost that much. Dr. Michelle Dritz is an adolescent pediatrician. She comes in, and in 2.5 hours, she does actually a semester's worth of a course in quality improvement, which does a lot on health statistics around the world to show where we are as a country and how we perform and how we pay more and sometimes get less and prevent issues. Dr. Brown is the department chair of emergency medicine here at Wright State, and he actually steps out of the role of physician. He comes in and walks the students through quantitative methods, queuing theory, project planning, and those type of things. The other classes are we have a negotiation session where we divide the folks up into students up into 2 groups and negotiate in terms of linear accelerator. And then the last one, which should ring true with a lot of facilities, what we call putting it all together. The class simulates the C-suite, the CEO, COO, CFO, and they actually have to look at 14 particular budget items that can be cut or modified to cut $1 million so they can open their doors on January 1st. We have a lot of fun in our class. It's very active, and I think it's successful because, again, we bring in so many outside guest lecturers. Next slide. I'm going to introduce the panel quickly. Now, the brochure that came out, you had that, but I'm going to do a quick introduction. I'm going to start with Dr. Hardy. Dr. Hardy is the currently chief of staff of the VA Medical Center. Prior to that, he was the vice president of medical affairs at Grandview Southview Hospital Medical Center for almost a decade. He also serves as the Dean of Veterans Affairs for Boonshoft School of Medicine. A little bit of background on Dr. Hardy. Dr. Hardy, before he became a physician in the Army, he was an infantry officer in 101st Airborne, and as a Ranger, he completed 2 tours of Vietnam, and advisor to Vietnamese infantry. Our next panelist is Brenda. Brenda is Executive Vice President, Executive Chief Clinical Officer at Kettering Health Network. Prior to that, she served as the Chief Quality Officer and Chief Nursing Officer at the network level. And prior to those 2 tours, she was the Chief Nursing Officer at Kettering Medical Center, and before that, the Chief Nursing Officer at Grandview South Medical Centers. She began her career as a staff nurse in critical care at the same hospital. Our next panelist is Jane Lachey, the minor. If you Buckeye fans look at that name, Lachey, and yes, she's related to him. Jane is currently the Chief Nursing Officer, Chief Nurse Executive at Dayton Children's Hospital. Prior to the current role, she spent several decades as a staff nurse, nurse manager, and director of nursing at Miami Valley Hospital, and was always on the leading edge of innovation. She's the current president-elect of the Ohio Organization of Nursing Leaders and has served on their board since 2009. She's also the past president of the Dayton chapter and is still the liaison to the Ohio Nursing Association Summit. Our next panel is Mickey Clancy. She's currently the Chief Digital Officer, Assistant Vice President for Oncology Services at Premier. Prior to that, Mickey was the Chief Operating Officer at Miami Valley Hospital. She's a Premier, and also before that, she was the Vice President and Chief Information Officer at Premier Health. She's been with Premier for almost 20 years. Mickey's a very proud Marine. The next panelist is Nick Lair, as Assistant Vice President for the Continent Clinical Lab Services. After getting his bachelor's degree at Xavier University, he did a 2-year fellowship that seemed like eons ago, Nick, at Miami Valley Hospital, and he's never left. He's been increasing hospital positions to include Director of Surgery, Vice President of Hospital Operations, Chief Purchasing Officer, and then he was the first Vice President of Network Development for the Premier Health Group. Nick is also an additional duty, as is with Mickey, the system coordinator to manage Premier Health's response to the COVID-19 pandemic. I like to say that I've had the pleasure of working with all 5 of these people as colleagues, sometimes as my bosses, mentors, and good friends. I think we've got a fantastic panel tonight. Our ground rules tonight are please stay muted for those who are not the panelists speaking. When we get through the scripted moderator questions, you can start putting questions in the chat box. When we open the phones back up to that, Leah will read the questions to the panelists. Please feel free to direct your questions to particular panelists if you'd like to do that. And the panelists will be visible, as you've seen this before, when they're speaking. I just want to forewarn you, again, that sometimes when someone's speaking, their voice may be in their picture, so don't get worried, just listen to their voice and we'll go from there. Next slide. Our agenda, I've done an introduction. We're going to have what I call a facilitated discussion for almost the first hour, where I'm going to give you questions. We're going to let each panelist have the opportunity to answer that question. And then somewhere around 6:45 or 6:50, we'll open up the questions for the audience. Leah will read those for us. We're scheduled to end at 7:25 to 7:30, but if we have more questions, and as long as the panelists don't have to run off someplace, we'll go beyond that if we need to. It's more important to do the best we can to answer questions going forward. So that's kind of the ground rules. That's the introduction of our panelists. As a moderator, I will try to get out of the way and just ask questions. So with that, we're going to go to the first question, and it'll be Dr. Hardy. So Dr. Hardy, and I'll get the same question. How did existing organizational policies and procedures succeed in responding to the COVID-19 pandemic?
Dr. Hardy, you are mute.
You're muted, Dr.
Ed, did you say we were going to introduce ourselves and we go to the first question, or have you changed the format already?
Dr. Hardy, you are. Thank you for keeping me on script. I'm sorry, Dr. Hardy. You're going to do the first 5 minutes. Thank you.
No, I don't want to throw the schedule off, Ed. Some of you might find it hard to believe, but Ed Siren actually worked for me back in the day, and clearly there were some lessons that I didn't get to teach him before he departed. He was a great employee, and I really was sad to see him go. I'm a chief of staff at the Dayton VA Medical Center, and my role as chief of staff here is a bit different than it is in your organizations, in that I have responsibility for all of the credentialed providers in the organization. And I also have responsibility for many of the administrative support staff and the nursing assets that support the clinics that support those credentialed providers. A week or so ago, Ed invited me to be part of an American College of Healthcare executives meeting in which we talked a lot about the very topics we're going to discuss tonight. And it only took the first round of questions for me to realize that we and the Dayton VA Medical Center as a federal healthcare facility are very different and have perhaps approached and dealt with the pandemic a bit differently than our partners downtown. We have different pressures, different mission, and there are different vectors pulling on us than on folks downtown. If you've never been to the VA or don't know much about it, I'll say that we are truly a vertically and horizontally integrated healthcare system. We have an electronic medical record that reaches from coast to coast and out into the Pacific and the Caribbean, wherever we have veterans. We are part of what's called Veterans Integrated Service Network number 10. And I think there are 21 of them around the country. Vision 10 consists of 3 states, Michigan, Ohio, and Indiana. And our providers are able to move around those states without the issues that providers in Ohio face if they go to Indiana or Michigan to work or to help with the pandemic. If you have a valid state medical license, you can work in any facility, and that really helped us, during the pandemic. Another thing that helped us during the pandemic is we have a large cache of equipment available to us during times like this, with tents and generators and tons of PPE that we could rely on during the initial stages of the pandemic, when those things were hard to get. It also enabled us to shift staff, equipment, and PPE to other facilities within Business 10, which we did. Detroit, for example, was a hotspot early on in the pandemic, and we were able to send nursing staff, ventilators, and truckloads of PPE to Detroit to help them out. We're also an HMO-like organization. We have a captive patient population. We are able to communicate with every one of our veterans and every one of our staff, of course, much more easily than perhaps you can in the community. So that's my 5 minutes in. Thanks for giving me 5.
Thank you. Brenda.
Hello, my name is Brenda Kuhn, and I serve as the Chief Clinical Officer for Kettering Health Network. That's a new role that we created just about a year ago, as we were wanting to focus more on creating one best practice across the network. And so I have the privilege of leading a network clinical exec team that includes a vice president of peri-op, a vice president of emergency services, a network chief nursing officer, a patient safety officer, a VP of ancillary, physician who's a VP for our outcomes. Since March, most of the work has been around incident command. We did stand incident command up as a network in addition to our campuses. And here is a picture of our network incident command. So this was early on, which is why nobody has masks on. But we were blessed to have a big vacant space that within about 24 hours, they put up some walls and converted it to an incident command for us. So as we have rolled out incident command, we have done that as a network, creating the practices once and then deploying them to our different sites, both our hospitals and our physician practices. If you go to the next slide, I thought it might just be helpful for those who weren't as familiar with incident command and disaster preparedness to see the different sections that we deal with. And so you have an incident commander who works very closely. For us, it was with the campus presidents to make sure we had alignment across the network. And then we have a safety officer for this pandemic. It was our infectious disease provider. We have a liaison officer, and then we have a communications person. Operations, we have 4 areas that we worked on for operations: our nursing, our physicians, peri-op, and then our physician network also reported into our incident command. And then we had an ancillary operations section. You can see the 4 areas listed there. We had our logistics, and then we had finance. And so all of those individuals were represented in that setting that we showed with the first slide. And each one had 3 deep. So as we were running 24/7, we had to staff each of these areas with individuals. So that is how we have managed through the pandemic. And I think we'll talk about some of the specifics as we get into the questions. Thanks, Ed.
Brenda, thank you. Jane?
Hello, everyone. I am Jane Geminer from Dayton Children's Hospital. I serve as the chief nursing officer. In addition, I was the co-commander for our Hospital Incident Command Center. Very similar to the slides Kettering, Brenda shared from Kettering. We had a very similar incident command center. Initially ran from March through May. We then went on to a modified incident command where we met daily for the last couple of weeks. Now we have gone back to a weekly vigilance and available as needed for emergency kinds of situations or discussions. Our number one priority through this entire COVID pandemic has been safety of not only our patients, our families, but our staff. And this is our top priority. Back in August, all of our employees committed to signing a pledge. And that was really that they would be committed not only while they were at work, but when they left our organization to following the rules of engagement that were set outside of the organization by either the governor and or the local authorities of their county and or city. We also continue to share that we're going to be living with this, we believe, for months. Some of the stuff I read today is the vaccines may not be completely rolled out until a June timeframe. So we are going to be in this pandemic state for a period of time. Some of the things that we implemented during this pandemic is initially weekly calls to all staff that we recorded on Teams for Debbie Feldman, our CEO, to be very visible with our organization. In addition, I have set up a CNO chat time, and I do that at least quarterly or as needed. So, for example, we made a decision about 2 weeks ago that we would be taking adult patients up to the age of 35. So the week of Thanksgiving, I hosted a CNO chat time with an open mic to answer lots of questions from our staff in regards to that. That has worked really well for us because those sessions can be recorded and then available for all shifts to be able to hear. And we try our best to keep the lines of communication open. We also have a fantastic marketing team that really helps serve us well. When we make announcements, make decisions to do things, they try their best to make them transparent to the community. And then we set up a COVID hotline early on for our parents. If they had questions about our kids, our outreach team took that on as an additional responsibility to be able to manage those phone calls. So if they have questions about what's an antigen test versus a PCR test, the parents can call in and get that information from registered nurses who man that outreach program. On the next slide, Leah, I'll kind of go over that we had 200 processes, and it's now probably 220 that have evolved and changed. We used our existing policy, if we had one, and made the modifications for COVID. If we didn't have one, we created a new policy and procedure. But I would say everyone on this phone call would share with you that was a lot of the time that we spent early on is making the modifications with the new restrictions and or new PPE process. The protective equipment continues to evolve. We implemented on April 1st, no April Fool's Day, the masking of all employees. 1 week after that, we implemented the masking of all visitors when they came in. And in August, we added on top of the mask for additional protection for all employees. We had implemented that in March for our emergency departments and those areas taking care of our COVID patients. To date, that's been a very successful strategy. I am so proud. We contact trace every exposure, and we have been very fortunate and blessed in our organization to say that most, if not all of our exposures have been from the community and from life outside of Dayton Children's. We have also, Adam Mezoff, my partner, the co-chair of our Hicks Command Center, has done a fabulous job of trying to keep the primary care pediatricians in our community very informed and up to date. So we created a toolkit and made that public to our pediatricians to help guide them. Recently, last week, we created a table of PCR antigen. We're going to add antibody testing to that after today's discussion, but just really to help clarify, because one thing I've learned about this is every time you think you know what's going on, something new comes up. I would say that we all are spending hours every evening trying to read the latest stuff so that we're as up to date. But we have been blessed with an internal scientific panel that we really ask them to kind of be the lead for keeping up on both testing and treatment to make sure we're as up to date as possible. Dayton Children's also formed a fall task force in collaboration with the Greater Dayton Area Hospital Association and our Montgomery County Department of Health to really help guide schools with the toolkit. Obviously, you guys have seen that the schools have had to pivot a lot, including in the last 2 weeks, most schools going back to online learning. But the collaboration between the adult facilities, Dayton Children's, all the facilities in the region, Ohio Department of Health, and the governor's office, we have tried to keep it as smooth as possible, all working together. Our current work is around surge planning, and I know we'll dive into that more because that is exactly where our Kettering and Miami Valley Premier system, I cannot say enough about what those systems are doing standing up for this region. It's amazing. Through it all, we have sustained a net promoter score greater than 84. We're higher than that right now. And we've had continued improvement in our hospital-acquired condition prevention strategies. This month, Dayton Children's was recognized nationally by the Solutions for Patient Safety for being the pediatric hospital for the month in the country. So those are things that we keep top of mind with safety. So thank you.
Jane, thank you. Mickey?
Good evening. I hope I have come off mute. I want to make sure that's okay. Thank you, Nick, for being my partner in crime. I'm with Premier Health, and I'm in a variety of roles at Premier Health, as Ed said, but my current role is I'm the System Vice President of Oncology Services, and as of 5 weeks ago, I'm the Chief Digital Officer for Premier. But the reason I'm here today is because I'm one of the 4 system incident commanders for our health system. Much like Jane and Brenda indicated, we stood up what's called an incident command center. It's a scalable center. Our center was quite a bit different than what Brenda showed. We ran a virtual command center where we had people all over the system connected through technology and working together through a series of Teams meetings and Teams chats to be able to stay informed and instructive to make very good use of our people's times. We have also used quite a bit of technology to have weekly team meetings with each of our hospital staffs and with our other entities. We have a very large physician network of employed physicians. We have Fidelity Home Health agencies that are that works in the home that we needed to do additional procedures and policies for. And we also have Samaritan Behavioral Health, and we have CompuNet Clinical Lab, which I'm going to let Nick talk more specifically about, that we needed to stay connected through this entirety. In addition to the areas that Brenda showed on her graph, we had a few extra areas of focus. We stood up an external community task force that worked very closely on working with local manufacturers and local organizations who were wanting to help the healthcare heroes and help create innovation to bring into our community to address some of the PPE problems and some of the other issues. That was extraordinarily successful and really helped us tremendously be able to stay in front of supply chain and pharmaceutical issues. But more importantly, it was able to help us keep our staff engaged and supported by the community. And one of the things that's the hardest during this pandemic is the impact it has on our healthcare heroes. They are working tirelessly. We have a lot of discussion about frontline staff, and it's not just in the hospital. Our Fidelity workers, our CompuNet workers, our physician network workers are all on the front line doing a variety of different things to assist in battling COVID. We also stood up a different kind of physician communication for us. We had online regular twice a week in the spring and once a week now updates for all of our physicians to be on, to ask questions, to get real-time answers. And that was wildly successful. It's a mixture of our employed physicians and all of our independent physicians to keep them in tune with what was changing. Like Jane indicated, I think most of our organizations changed almost all the same policies and procedures as we went through this because we worked on them together. So we had also an arm stood up that was dealing with coordination with the Greater Dayton Area Hospital Association and the Health Collaborative down in Cincinnati. Our hospitals range, like Kettering's, between 2 different regions that became Zone 3 midway through this pandemic. And so we had scientific experts as well as clinical experts that worked with both organizations to create some very robust surge planning. One of my major responsibilities during this was the surge planning of the hospitals, and we were able to figure out from an engineering perspective and from a clinical perspective how to stand up as much internal capacity as possible to make most efficient use of our staff. And so that became a major league focus for us. And we're putting that into play right now. And so far, so good. The plans are working as designed. I think the last thing that I'd like to talk about is the staff support team that we stood up that is spending a tireless amount of effort making sure that our staff have what they need. We stood up a Helping Hands organization that is people who work throughout Premier and a few other people who are coming in from outside of Premier that are working on the floors to help our nurses and help our environmental services staff and our food and nutrition staff to be able to take great care of our patients. And so this is one way we work together collaboratively as a team to solve the problems that we have. But this also is a team that's working on the spiritual needs, the emotional needs, and the physical needs of our team. So helping to serve up food and support, helping to find respite areas, helping to find counseling and downtime, because life goes on during the pandemic. And when these workers are working the number of hours they're working in very difficult times, they often need more arms and legs than they do on a normal day for providing the healthcare heroes part. So we've been spending a tremendous amount of time with that. And I think I've hit my 5 minutes. So I will stop there and let Nick continue with any other things that I might have missed in Incident Command. And I look forward to talking to you in more detail as we go through the questions.
Mickey, thank you. And I want to thank you again for being one of our guest lecturers. You're always very helpful. Give information. Nick, you're next.
Sure. So for me, I am the Vice President of Lab Services. So before I get into the lab, I just want to make a couple points on the Incident Command. I think for all of us, we've been well trained on how to support and manage a HICS disaster plan. I think everybody on the panel over the last 20 years, we do testing. We practice disasters, and this one has been. It's a little like the ones that we've practiced and or gone through, but the breadth and the scope is so wide, and it's not just a one event. So when we all practice and whenever we had a disaster, no matter if you were a system or if you were a particular hospital, no matter what city, you practiced an event. So you had a fire, you had a tornado, you had a water main break, and you worked for 48, 72, 96, 2 weeks, 3 weeks, and you ran your HICS chart and you ran your team and you worked with your teammates, and you knew there was an end. This has been an event like we didn't imagine. So, Mickey talked about it a little bit. Is Premier? There's 5 hospitals. We cover 70 miles. Much like many of the other systems and hospitals, it's not just a one site disaster. So the complexity is incredible. The virtualness, the being able to communicate to each other and really kind of feed off of each other, because you might have a question in Hamilton where the physician had the same question in Bellbrook. You have an employee, it's just the breadth is so wide. So for us, we had to quickly learn how to manage a disaster or a pandemic using more than just one site and not having an end date. So you have to take care of yourself, much like I'm sure everybody here. If you're in healthcare, there's a small part of you that really gets your energy levels go up, your adrenaline starts going up during times when the community needs you. But you got to remember, this is not a 24-hour event. This is a 24-month event. So there's the challenges of the HICS chart, using multiple different sites, using multiple different constituents that you're working with. And when we talk about system, it's not just Kettering or it's not just Premier that Mickey and I work for. It's really it's now partnering with systems that are across the street, down the road, to help each other out, learn from each other. Hey, do you have this policy? Let's do this together. Because as a citizen, as a community member, you want to hear one message, because the messaging is impossible. You watch any news outlet, you read any paper, you read anything, you get conflicting information. And for us together, we've always tried to make sure that we're singing out of the same hymn book. Because if you're a community member and you watch Channel 7 or whatever, you do want the Dayton Children's, the VAs, the Wright Pats, the Ketterings, the Wayne and the Wilsons, then the Springfields to say, you know what, we do know what we're talking about. We are providing the best care, not only in Southwest Ohio, but take us to New York or take us anywhere, and we feel we are clinically a superior in providing the best care for wherever you live in the Dayton area. So that's kind of been an eye-opening thing for the disaster HICS for at least where I've been working with Mickey and quite frankly, really everybody on the panel. The other topic is the lab. Also, when you look at the traditional HICS chart or when you look at a traditional disaster, lab's not even a box on the chart. We're in the basement. Rarely do you ever come down to the lab, and if you do, you're lost. And then we quickly give you directions to the cafeteria. So this has really turned us in the lab world a little upside down. We've had to quickly go from crawling to walking to running to flying to support the community. This is a testing disease. We have to test. We have to determine our clinical pathway based on that test. So we were, once again, because of this being a little unorthodox in the breadth and the width of this disaster, we were brought into situations that we were a little uncomfortable and not really trained for. But that's why being in healthcare is so awesome, because you rely on partners who do this in their sleep. So, I don't have to go into the testing world, but we're talking together through Gadaha because we're learning, we're buying, we're turning on, we're communicating what's the difference between a PCR and an antigen, as Jane had mentioned, because everybody's got different answers and every study has a different conclusion. But you got to go with your gut. You got to go with your clinical experts that we have in Dayton, Ohio. I wouldn't trade any expert with the group that we have in Dayton, who can give incredibly clear and concise leadership. So it's been very nice. So that's a little bit of the continuation of Premier's Incident Command, and then of course the lab world that we're living in right now.
Nick, thank you. Before I go to the questions, I want to thank the 60 folks who dialed in. We're glad you're here, and we hope it's rewarding. You got a very, as you've already sampled, fantastic panel. Just one parallel note, one of the things that we talked to the students in this class about is that we're talking about leadership in healthcare entities. Reality is the leadership things we talk about, you could apply to any organization, not just healthcare. And we talk about how complex a healthcare organization is. I hope you've just realized in these introductions how complex just managing this event has been for all these facilities and how fantastic our folks have done. I think later on, when we get to the questions, you'll see how adaptive and resourceful these folks have been. So, Dr. Hardy, I'm back on script now. So you get the first question. How did existing organizational policies and procedures succeed or not succeed in responding to the COVID-19 pandemic?
Well, I'm reminded of that old military expression that the best battle plans fall apart upon contact with the enemy. And many of the members of the panel have already addressed how they have adjusted their policies and procedures over time. And we certainly were no exception to that. If you look at our policies and procedures that existed in early January and February of 2020, look at them now, it's almost like we have a different organization. Employee health, for example, infection control, even the relationship with our union providers. I don't think there are any other facilities on the call that have both nursing and physician unions in the organization. And all of the policies, including those with our union partners have changed dramatically. The important part of all the policy changes has just been how we managed to communicate this. And I talked earlier when Ed gave me my first 5 minutes about how I think we're fortunate as an organization organized like an HMO and vertically and horizontally integrated to be able to send a message out to every patient and every staff member simultaneously. And I think that no matter the changes that came about to the policies and procedures, how we communicate those things to our staff was really the key to our success.
Thank you. Brenda?
So we as a network have created policies that are the same across all of our organizations. And that was key as we responded in the pandemic. So when the governor shut down surgeries for elective surgery, we actually consolidated our surgeries to our trauma centers and our hospital down in Hamilton. And so because we have the same policies, because we built Epic the same way, because staff were used to the same practices, we were able to redeploy the surgeries that were going to be done essentially overnight to a different campus. So that has served us very well as we looked at how do we do one thing consistently across the network. Where we're seeing that today is as we're moving staff from one site to another based on demand, the same thing comes into play. Because we've created practices as a network, staff are able to go from their home department to another campus to provide the support that's needed. Having healthcare has a lot of policies. And so often it was modifying a policy versus creating a new one. And then the challenge of getting that communicated to all staff. So I'm sure all of my colleagues had emails that came out from Incident Command with a very specific look. So it was obvious to people that this was a policy related to the pandemic to allow them to keep track of them. And then the other thing that we did was we put the most recent version on the intranet. So if you think about visitation, we had open visitation before this. And then we limited it to one visitor per patient. Then we said no visitors. And sometimes we wouldn't even have the signs made for the next version before we were changing to the next version. And so we found that keeping the latest version on the intranet, so it was easy for those things that were changing frequently, allowed staff an easy access to know what was the latest if they had been off recently.
Thank you, Brenda. Jane?
So I kind of included some of this in my intro. Then we would modify based on CDC or governor guidelines. So I'll give you a simple example that we can all relate to, the travel policy. Initially, we created a very short and sweet travel policy. There will be no business travel. If you are traveling outside of the states, be mindful of the governor's restrictions that he has established for travel. Initially, we allowed no travel. We then opened it up to just follow the governor's guidelines, and that's where we exist today. Our business travel has been suspended except for, like, we had to get somebody trained on Epic, so we needed them to go on site to Madison to get the Epic training. But other than that, we are doing everything virtually. So that's an example of a real impact to business in a way that we have really forced ourselves to virtual learning and virtual networking, which again has worked out beautifully. Another thing operationally that I think we'd all agree with is we all had teams probably as a foundation or a similar system, and we became team super users pretty quickly, where that became our foundation for communication, because each and every one of our organizations and departments through Dayton Children's is limiting people meeting in a group. We have really gone to virtual meeting or making sure we can be in a room that we're at least 6 feet apart with a mask on. So that changes how you do many things, including orientation, including, you know, having that touch point to make sure people know who you are, what your face looks like. We modified all of that to make sure that we structured our programs in a safe way. Operationally, things like doing CPR class or doing PALS class, or how we do our Crisis Prevention Institute, which is training to de-escalate patients and or family members. All of that had to be modified with COVID, PPE, and safety instructions in mind. So it's every aspect of our day was impacted by COVID, how we do things, how we eat, how we celebrate, and create. I said this to Debbie on week 1, that agility was going to be the key feature of this virus, and how agile we were is going to really come out. I know a lot of organizations use the word pivot, but we have had to change our pivot all the time. But again, what's been key is the collaboration between all the organizations in this community. And I think all of us appreciate so much how collaborative this effort's been to help take care of this community and all the citizens within this region.
Jane, thank you. Mickey?
So, I mean, a lot of our story is very similar to what's already been said, but I'm going to use a couple of different examples of where we already had policies and procedures that worked really well. One of which was our disaster plan. So we actually were able to scale our disaster plan differently in the spring than we did in the fall. And so we didn't have to go through a ton of change of policy and procedure because we had already built agility into that policy and procedure. And in some areas, we were able to operate as hospitals independently where they might be experiencing something different. And in other areas, we were able to do it as a system as we needed to do something systematically to be able to make things consistent. One of the things that was a big adaptation into our policies and procedures is we were not used to doing a community collaboration on every major tweak and change we were doing. And I see Brenda laughing because it took a little bit to get used to 2 and 3 major competitors to work together to agree that we were going to do this as the community to make sure that we were all following the best guidance. And with so much different guidance, especially in the spring, coming out from different national organizations and the CDC, it was very hard to land on what was specific. You know, do you have to take a temperature versus do you have to attest to a temperature? I think we spent weeks having a debate about which one that was and which one shouldn't it be. And we had to finally land on what could we practically put in place in our organizations. And while they were significantly the same between all the different organizations in our community, they had to be tweaked by what equipment people could get and what staffing that could be put in place for that to be accomplished. And we would communicate collaboratively to make sure we knew where the similarities were and where the differences were so that we could address any questions coming from the community. Because safety was the most important thing we were working through. And if somebody says this is the best safety and then they see it look a little bit different when they go to another organization, you have to be able to bridge that gap so the community knows we're working on that together and we're being safe together. So that was a very different way of doing policies and procedures. We thought it was hard to do it amongst 5 hospitals and 4 or 5 other entities to be consistent. It's way harder to do that across the community of Cincinnati and Dayton. I think I'll stop there and let Nick pick up because he did a lot of the operational work in the command center. I did more of the planning work. So Nick, do you want to take from there?
Yeah, thanks. So if we go back to March 16th, when we were quickly standing up the system-wide disaster HICS chart, one thing that was important is we had one labor pool. We had one operations team. We had one, so basically all the different entities were already collaborating with each other. And we actually identified some policies that were, historically speaking, a little different. Premier, over time, is made up of different hospitals with different policies and procedures. So as we've all wanted to have one base policy for any topic, reality is that there's different hospitals have different policies over a long period of time. Well, these events quickly brought to surface how different hospitals might have different policies and or operated differently. So what we had to make sure we were doing in March, April, May, June, and all the way up until today is that we did function as one unit. We have to function as one unit. Unless there's the Miami County Public Health Department wants it done this way, and the Montgomery County Health Department wants it done a different way. There's always some caveats, but we quickly had to realize as a family, as a system, that we needed to be on one common ground, one common process or policy. And quite frankly, what we did is we looked at the market and said, hey, what are other places like us doing, and what does make sense? So, historically speaking, we might all suffer from analysis paralysis, and it would take us, 12 months to change a policy, or it might take us 12 months to tweak a policy. We didn't have 12 months. We had 12 seconds because what was happening is the market was moving so fast. The communication from the news media was happening so fast, and a lot of times the message wasn't correct or it was confusing. So we, as a system and actually as a community, had to work quickly on so many different decisions, and then we had to bake it into a policy, and then we had to live by it. And honest to Pete's, on Monday you say, okay, this is the policy, and you communicate it to the system. You do a little check 7 days later, and you find people start deviating. You can't let that occur. So what was important is, though, that we did have subject matter expert teams that handled the question. And that's, as a chair of operations during the HICS disaster, what you do is you have different subcommittees where they are in charge of that question, they are in charge of that policy, and they have to refine it to the best of what questions on the table. I will say a couple things, though. One thing, there were some non-negotiables. Even though policies were changing hourly and daily and weekly, you always had to adhere to PHI. I mean, there are cardinal rules in healthcare that you can't deviate from, no matter what kind of disaster is in front of you. You can't text information. For us, it's not a secured modem. So we had to make sure that everybody was talking, everybody was sharing information, but you also had to say, time out here, hold on. We have to follow a lot of our core policies. Also, there was a lot of stuff in regards to cyber. A lot of people were sending emails to anybody who wanted to get, so you had to be very cognizant of even though we're running around with a lot of to-dos, you had to make sure and be very mindful of the common policies that are still there. CMS, Medicare, even though the governor was coming up with new orders every other day, we had to still be very mindful of those policies that we did have into place and still adhere to them. So it was amazing to see a lot of things that changed. Analysis paralysis, where a lot of people take so much time because they want to cross their T's and dot their I's, and they want to do that calculation one more time. We didn't have it. So we did make changes quickly. Sometimes we got it right. Actually, most times we got it right. Sometimes we didn't. And then we had to send out another email saying, okay, time out. We forgot a word, or we forgot a simple sentence that we thought was just an assumption, but we had to reword things. But I think the employees and the community members, they understood that things were happening so fast that patience was a virtue, and it's been rewarding knowing that the teams are executing and functioning where it's need to be done.
Nick, thank you. Dr. Hardy made a comment earlier about we had a panel discussion for the American College of Healthcare Executives a couple of weeks ago that I was moderating. And Dr. Rob Cologne from Premier was on that panel. And we were talking to him about how many times he was interviewed. We were kind of, making light of that. And I would say, Nick, that I think the picture of you at the Dayton Arena under the tent was probably on TV more often than Dr. Cologne got interviewed. So I think you probably lead the pack. Do you get royalties for that? No.
Do I? No.
Okay. Throughout this whole thing, we talked about the organizational policies and things. I want to shift gears now and focus on this question is about the people. So this will be Brenda, you get to go first. How have you managed and cared for your staff to both keep them healthy and on the job caring for your patients?
So great question. Jane talked about the focus that we have all had on safety first. And so that has been a high priority. So if you think back to March and the fear of the unknown, so one of the things was making sure we were available to answer questions. Immediately as this rolled out, we wanted to make sure we had adequate PPE, the personal protective equipment, and that staff were using that equipment to protect themselves. And so rounding on our staff, understanding what their concerns were so that we could make sure we were addressing that was one of our key factors. When you think about the fact that the school shut down, to keep the staff on the job meant we had to help them with their childcare. So we partnered very early on with the YMCAs to provide childcare for our colleagues who would need that to be able to work because they had their childcare arranged and it was school, and then all of a sudden that wasn't available to support them. So looking at what resources we could provide them to support them in their home life, as well as what they were doing at work. In addition to making sure we kept them physically safe with the PPE and social distancing and just all the safe practices, we also put in place things to support them from a mental health perspective. The emotional toll of those caring for patients who cannot have their family members with them, who are on units with doors closed, is unbelievable. And so providing support to our frontline staff through respite rooms, through areas where they could pick up a snack and a beverage. We have our chaplains that created different programs they would round. They had a chaplain chat. So if you wanted to just talk with somebody, you could do that. So really focusing both on their physical health, especially for those who are in our healthcare settings, and then making sure that we were taking care of them as a person through some support for their mental health.
Brenda, thank you. Before I go to Jane, for those on the program, you might want to start getting in line in the chat room. You can either type your question in when we open it up to you, or you can just say, I've got a question, and Leah will let you in, do that. So Jane, same question. How do you take care of your staff?
You know, that the staff have been top of mind, my constant worry. Those are in the early days of March, that was the sleeplessness that Adam and I had to make sure we created the best system from a protection standpoint. So we have been really committed to that. In addition, Brenda reviewed some great things that Kettering did. We have not had as many resources from an emotional standpoint, and that's one thing I do worry about, because this is a marathon and the marathon's taking its toll. In the pediatric world, we have had over 3,000 children in this region that have been positive for COVID. Fortunately, the majority of those children have not required hospitalization. Those that have, about 10, it's probably closer to 20% of the hospitalized kids have had that what's called MIS-C, which is the multi-inflammatory system COVID. When those kids come in, it's that intensity of caring for a child that's got more than one organ that's been impacted by COVID. And so you worry about that. I think the other thing from a pediatric standpoint, my worry zone is the emergency department and our pediatric intensive care unit, because traumas in our world have been up significantly and child abuse has been up significantly. That is also a burden emotionally on staff. So keeping all of those things in place and then really building the support system of the managers and the support team around them to make sure they're listening. One of the things we got committed to is Nurse Recognition Month rolled around. We chose to have it, and we did it differently this year. We did it virtually. We created very innovative ways and had a celebration for the month and did different things through virtual world to help the nurses feel very, very, I hope, appreciated and respected through that. In addition, we have done that same methodology for recently. In September, we honored our respiratory therapists for their month. And with that, we also did a virtual recognition. So the creativity of the team has come out. There are ways to keep things moving that we've really relied on. And I will tell you, if you have your clinical bedside clinicians involved with helping, with those creativity things, we then have the opportunity to implement it. But I cannot tell you the emotion and the tiredness, and I can only imagine where our adult facilities are, because I know for ours, it's just the rigor of keeping up the policies and the procedures. And, the volume is really in our adult facilities, and that's where I'm sure that burden is really.
Thanks, Jane. Mickey?
I talked a little bit about what we're doing for staff support in my intro, but I would like to add a couple of things that I think were really important. One of the things that has been very challenging is, in order to stay financially solvent through this, we had to work on having some ways for people to furlough or have some time down during this if they were in a position that was not necessarily critical at the moment. And so we had to do some emotional and helping support for those individuals too during this. So we put in extra communications and extra touch bases in virtual rounding so that those folks would know when, that we would need them to come back and continue to work with us during this period of time. And many of those individuals are the individuals who are serving in the helping hands roles during this fall area of our pandemic. We also had a tremendous amount of chaplain support, of them rounding virtually, carrying on some open prayer sessions, some open meditation sessions, some open just talking sessions that were held virtually that people could come and sign up for, and almost have a little bit of group therapy together to be able to rely on each other to continue to walk through. Winston Churchill has a great saying about going to war, that sometimes the best way to get through a war is to go through it. And so we in this pandemic are actually having to keep marching forward every single day, even if we're exhausted or haven't had time off. Many of our folks not only are working overtime and double shifts and extra duty, but a lot of folks have struggled to be able to take time off with their family. And so we've tried to have some protected times that, even if somebody was able to take a vacation day but had to do 2 hours of work, we tried to protect the rest of their day so that they could have that time off. And a lot of that time was done teammate to teammate so that we could help support each other through the fatigue, because it's a different kind of fatigue, because not only are you worried about your patient, you're physically tired, but you're also worried about your family and who's taking care of teaching the child at home, and who's taking care of mom, and who's taking care of your sister, and oh my, life happens, and someone gets ill with something else, and what do they do? So those support groups were really, really vital to be able to have some extension and some relief while they were at work, to be able to rely upon their work family to try to help through the crisis. We were also extraordinarily thankful for the community, the amount of people who made masks, the amount of people who brought food to the hospital, brought meals, brought snacks, we had Crocs delivered to all of our hospitals so people would have shoes to help take care of things during the pandemic. And to be able to distribute those provided such gracious thankfulness to our staff, because they knew that the community was behind them. It wasn't just the organization behind them, but they knew the community was there to help. We had a nursery deliver all sorts of spring flowers that we were able to give out to the staff as they were leaving. We had pumpkins come during the fall to be able to give out to staff. And those little things meant a tremendous amount to our teams to be able to keep them going. So those were some of the other things that we did and were able to take advantage of, in addition to what I talked about in my intro.
Mickey, thank you. Nick?
Based on everybody's presentations, everything has been said. I will say that, as Jane said, this is a marathon. And I think, Brenda, you talked about, going 3 deep. You need to have a core group of individuals who can help and rely on each other, because you as an individual, whether you're hourly or salary, you can't do everything 24 hours a day, 7 days a week. So if you can break it down into 3s, it allows you to sleep. It allows you to eat dinner with your family. Because what's happened is there are a lot of things that are happening every day, and whether it's reporting data to ODH, the amount of data that has to be reported to everybody, and it has to be done by 9 o'clock, or it has to be done by 11, or this person wants a report by 3. What happens is you kind of you take it on yourself, and you just can't. So what you do is you rely on your 3 deep. You rely on your partners. I think you've heard through the different examples is you have 3 names almost in every box, and you have the first person, whether it be Monday morning, and then you're always helping each other, because you do need time off. Even the most dedicated employee who will never give up, you give them mandatory time off. You have to leave the facility. You have to decompress. You have to get out of where you are, for the good of everybody's physical and emotional well-being, because nobody can take on this marathon as one person. Doesn't matter if you're hourly, you can't work the 16, 20-hour shift 7 days a week. You can't do it. So you have to almost look at each one of these employees and say, you know what, I appreciate your dedication, and I appreciate you like you wouldn't believe, but you got to go home. So it's you gotta monitor all your employees. You learn about your employees' family that you never knew before because things come up. So it's without the staff, you can't run anything. You can't run a disaster plan. You can't run a unit. You can't give patient care. You can't do anything without a human being doing it. And you could have the best policy, you could have the best computer system, you could have the best facility, but if you don't have the people in a good state of mind and an emotion, you can't get it done. So it's you've had to kind of you have to manage all that.
Nick, thank you. I think Dr. Hardy has stepped away. He had an emergency room issue at the Dayton VA. I looked in the chat box really quickly. I don't see any question there yet, so I'm going to go with one more question before we open it up. In the classes that we have, all of our guest discussion leaders end their discussions with an exercise, which is a practical application of what they talked about. So here's what I talked about. Now you try to work on it. Along that line, I'm going to ask a question related to, I'm going to say it, the umbrella I'm under is you know a lot more in December of 2020 than you did in March of 2020. So that's kind of where my question is coming from. What are some learned takeaways that have been developed to improve for the future and be better able to prepare for this current new wave of COVID cases? And Jane, you get to go first.
Well, again, in our pediatric world, the majority of our kids are coming in through the emergency department or urgent cares or Kids Express having symptoms, and fortunately their symptoms are not requiring an inpatient hospitalization. So that's a great thing. But for this next wave, where we really tried to stand up is we knew from our GADAHA surge capacity meetings that our community needed Dayton children a different way. So one thing we did 3 or 4 weeks ago was say we will welcome anybody from 16 to 21 while we worked on our inclusion criteria to take care of adults up to 35. That was something that we knew we had to stand up in this next phase. I hope all of you have figured out that this pandemic is real and that it is impacting this region, this state, this country in a way that I don't think any of us as leaders have ever come to grips with, and we are still learning every day. So what we did is stood up a group of physicians and nurses and respiratory therapy and all professions that help support those services to stand up an adult care committee. From a facility standpoint, that meant early on, back in March, we invested in getting more negative pressure rooms on one of our largest units in the hospital. We also evaluated adding some more negative pressure rooms to one of our tower facilities. And right now we've got that on hold because we need the beds in case we need them for adult care patients. But it included both technical, scientific information, but the safety of non-adult physicians, pediatricians really extending themselves, the nurses extending themselves to take care of patients. So that for us has been our major response to this third wave of COVID patients. And again, our goal is to help support the adult hospitals to the best of our ability.
Jane, thank you. Mickey, same question.
So from our perspective, we actually learned a tremendous amount from the way that we interacted in the spring to now. The science is better. We have a better idea of how the patients are going to be cared for. We did a lot of innovation in the realm of convalescent therapy for plasma and things like that we were able to put in place. We were able to stand up operations much quicker than we had probably ever done in our careers. And so we've been able to take that agility and move it forward. so that we could pivot and not, we adopted a model of not letting perfect get in the way of good. And that has served us really well as we've gone forward. When we scaled up for the current surge that we're in, we did not need to stand up every portion of our HICS chart. So we're only standing up portions as we need them as it goes, which is allowing more of our teams to be on the front line, helping to care for patients. I think the other couple of things that we really did differently was our labor pool and our staffing models in this fall, as we were beginning to learn how to create more arms and legs when you don't necessarily have more people. We have been learning from many, many other organizations who have gone through a large surge for how they extended their teams and operated in a different way. So where on a normal day, we might have a nurse that's a 1-to-3 ratio with no supporting helping hands, we might be able to go to 1-to-8 with certain kinds of helping hands that are clinical and non-clinical to be able to help provide more care. And that allows us to expand our expertise in a different way. We've been able to do that also from a physician perspective to expand our expertise in a different way. And that gives us the capability to surge differently. So a lot of our planning for surging, for having more patients, we actually did not run out of equipment or run out of rooms before we ran out of staff. And so really finding a way to extend our staff and do it in a sane and compassionate way has been our biggest learning from all of this planning effort, for how we stand them up for education, for how we equip them to do certain tasks a certain way. I think that this is a way that helps us get through the marathon journey that we're on, because we're going to still have quite a bit of work to do even after this particular surge goes, because it's going to take a while for the vaccine to take effect, and we're going to have some flu season hit us on top of that. So that's a normal for us in healthcare to have a flu season in the spring, actually the first quarter usually. And so those are the kinds of things that we've learned to do differently as we've progressed through this pandemic.
Mickey, thank you. Mickey, thank you. Nick, anything?
Yeah. So just I'll summarize it with one word: innovation. We were forced to innovate on many things. We can go back and kind of smile at this, but telehealth. If we had 10% of our visits were telehealth, we thought we were doing really well. We went from 9% to 70% in a day. Scheduling, before, how did you schedule? Well, you had to call somebody, or you had to go through a 15-page document. Now you got to schedule online, and that needs to be done in 20 seconds. My chart usage, we would have been happy if our physicians and our patients, used my chart. Now it's ingrained in almost every patient's healthcare. They know how to get to my chart so quick. Dashboarding and analytics, the ability to manage a department or manage a process. We would have had 92 meetings just to figure out where the source document is. We don't have 92 meetings. We have 1 minute to figure out where is the source document and put it in the dashboard so we can figure out where we are. So at the end of the day, we as systems are probably working so much more efficiently because of the innovation, onboarding of employees. It could have, you have to go through your regulatory things. You have to go through your boxes whenever you hire somebody. But now to hire somebody, it can't take 3 weeks. It can take 3 days. So obviously I can't give you details about that. I'm not an HR person. But at the end of the day, the innovation has been incredible. And where we were before March 16th to where we are today, I do smile knowing that we as a community or we as the systems are much more innovative than we ever were, because we've all wanted to do these things and we just couldn't get there. And we are there now because of, unfortunately, the situation we're in. But we didn't have time. We don't have the people. We don't have the extra 25th hour in every day. We still have only 24 hours, and we got to get this done. So the innovation's been awesome.
Nick, thank you. Dr. Hardy, are you back yet? Okay. I want to switch to Q&A, and what I had promised the class was that we'd let the first question go to one of our students. Charles, you'll be question number 2. So, Leah, is Cassidy ready?
Her question was answered by Vicki Clancy.
Cassidy, why don't you tell us what the question was?
Good evening, everyone. Can you hear me?
Yes.
Great. So I was going to ask about the surge planning, kind of what goes into that. But I am curious, as you've continuously needed to plan and innovate, just in anticipation of 4 potential surges, what has been the biggest obstacle, or what's something that you didn't anticipate or measure, or an operation that, looking back, would have been helpful to have in place before the pandemic?
Who wants to take that?
I can take that if you'd like. That's been my life for the rest of most of this year, is that surge planning. And I think there are a couple of things. We practiced a pandemic as a community a couple of times. And the one thing that we did not do when we practiced was, how are we going to, as a community, surge at 120%, 150%, 170% of our normal volumes and still take care of the entire community? We have a lot of smaller rural hospitals in our region that fill up pretty fast. And so those of us who have large hospitals are used to taking transfers from them. But we're not always used to, what do we do when we're filling up to do that? And I think one of our biggest learnings in the surge planning, and John from Kettering, who's not on this call, who's Brenda's colleague, and I work together quite a bit on the surge planning. And one of the things that we rapidly came to an understanding in our community is that putting up an alternate care facility in a convention center was not necessarily going to be the best way to solve our staffing problems and our community treatment problems, because as this disease was progressing, the amount of ventilation and critical care that was needed would require so much staff to come out of our current capabilities in our hospitals to staff that we couldn't take care of our normal operations well. So we really worked very collaboratively together to look, and we did this with the National Guard as a community, to look at inside the walls of each of the hospitals that exist in the greater Dayton area. How would we surge into doubling patients into a room? How would we surge into non-traditional areas? So if we slowed down surgery, which in the spring we had no surgery except the emergent surgery. So we had a lot of capacity in things like our PACU, our recovery rooms, our pre-admission areas, our surgery centers that we could tap into. Now in the fall, we are not shutting down elective surgeries. We're load balancing those surgeries to try to take care of as many people as possible in the community. Some of those spaces are not available. So we've had to adjust our plans slightly so that as a community we can surge within the walls of our hospitals as best we can. Jane brought up the great way that Children's is looking at how to help with that community surging. And we also are working with our local, there's a Kindred hospital in our region, rehabilitation hospital, There's other ambulatory surgery centers, nursing homes, assisted living homes that we're all trying to work collaboratively with to be able to put the patients in the right care setting to get the right care that they need. And this time around, unlike some of the spring work on that surge planning, we're in the middle of the surge while we're making those adjustments. So we were preparing for it in the spring, but it never got to the levels that it is now. So, we really had an opportunity to practice that together for how that would work. And now when we're having dialogue together as a community for how we're going to share the load, we have a lot better understanding of each other and how we might be able to function because we physically took tours of each other's facilities so that we would know how we would work together for that. And I think that's been extremely valuable for us as healthcare as a community asset, that it's not just about what we do on a day-to-day basis. It's also how do we take care of the community during this kind of scenario. So I hope that answered your question, but our biggest barrier is still going to be staff. Just so you know, it's always going to be staff. I don't know if anybody else wants to weigh in.
Brenda, anything to add?
I would agree. I think in the spring, we thought our biggest barrier would be space. And as we learned from New York, they set up the alternate care sites, but there was nobody well enough to go to them because you had to be stable, no oxygen, and those people are being managed at home. And so we've experienced the same thing that Premier has. We have beds and equipment, and it's the staff that will become possibly the rate limiting factor. And so planning ahead and bringing in travelers, especially in nursing and respiratory, the areas that would be hit the hardest. I would say another thing that's been very helpful, the payers have stepped up and created some waivers for partnering with our SNFs. So we're able to send patients that would qualify to a skilled nursing facility sooner than we normally could and without a pre-authorization. So the partnership hasn't just been with the other hospitals in the community, but it's with the other community partners like our SNFs and the payers to say, we realize it's going to be critical to keep our hospitals with patients moving through. And so we want to make sure we're taking our part in that process. I think one of the things that we set up in the spring that we stood back up about a month ago was a cascading of meetings. So at 7 a.m. we have an incident command, a very small group. At 7:30 we have a report in from all the section chiefs. We have 2 nursing calls a day looking at patients and staffing. We have a call with all of our critical care physicians and our CMOs and our hospitalists every day to talk about what they're seeing and ways that we can better support them. We do a report out at 4:30 to all of our senior leaders. And in the midst of those calls, we have community calls. So as we've talked about through other questions, we're able to collaborate to better support each other through this process.
Brenda, thank you. We're going to take 2 questions. We're going to do Charles Miller first, and then Krista, you'll be after Charles.
Charles, did you have a question?
We seem to have lost Charles. Let's go to Krista.
Hi, can you hear me?
Yes, we can.
So my question is, how are you able to decipher the truth from fiction when the pandemic just started? Like with all the mixed information and the signals, how and where are you able to get accurate information to tell what's really going on?
Brenda, I think as the Chief Clinical Officer, you should take that one first.
So we look at multiple sources. We follow what the CDC is doing. The Ohio Hospital Association and our local hospital association, GADAHA, both provide resources to us. And then on our community calls where we have experts together, they're all looking in their individual bodies of literature and bringing that information forward so that we can look to make decisions. So I think about our infection preventionists, they are seeing things within their literature, and I'm not going to call it research, but we have different studies where there was a group of patients or a situation. And so by looking in the different bodies of research, we're looking at what is the most current. And I would say that changes with some of the treatments. What we thought was the appropriate thing in the fall or in the spring, as we've gotten more insights, there's different direction. And so it's really just staying on top of what's being published to try to help with that. And then talking to your colleagues and talking to colleagues who are a little bit ahead of us in the wave was very helpful, especially in the spring.
Brenda, thank you. Charles, he's back on.
So, do you see his question in the chat? RH positive versus RH negative viral expression and testing.
Brenda, can you see the chat?
I can.
Charles, could you elaborate a little bit on what your question is?
Yeah, this is Nick. I don't know what this means.
Okay, so I have a question. Oh, okay. It says, does the antigen test have calibration to detect if it's in blood typing?
Does antigen? What I can say is every instrument that any institution uses that is CLIA approved has to go through what we call validation. Validation to turn it on and validation to every day. So whenever, for example, whenever we run the Lyra, it can run 80 tests per tray. We do have to, within those 80, put 7 blinded with variation on 7 different tests that are predictable, meaning we already know what the answer is before the instrument runs it. And depending on that test, we need to make sure that the accuracy of those 7 that were random are in fact true. So we in the testing world try to minimize variation as much as possible, and we do that by doing things with validation and doing QA, making sure that the answer from that specimen is in fact the answer it was supposed to be. Now, is it perfect? No. Do we do 100% QA on 100%? We don't have the space and time for that, but we do random sampling, and we statistically minimize variation. So that's a CLIA standard. That's a CLIA requirement, and that's done by every lab from coast to coast. The vendors, the instruments that are sold to us, they require that, and they're also the ones that send us the validation specimens. So it's without a doubt minimizes variation as much as possible. There's a question about payment.
I think Charles added on, how hard is it to establish a classical control?
Well, I assume that's emergency use, authorization use, and for those vendors that are trying to establish a product or a test. I don't know the research component that you're asking here, classical control versus placebo. versus different populations, I don't know that answer. I think that's what you're trying to get at. Are you talking about the creation of any instrument, the creation of any test, the creation of any virus, immunization, vaccination? That whole research protocol, I don't know.
Okay, so we have our next question is from Dean Berman. He said, all the panelists have talked about staff as a key, I just lost it, as a key to managing the pandemic. His question concerns the added burdens, both financial and psychological, that are immense. Does your organization waive payments or help with deductibles and copays for those staff who contract COVID or need mental health services as a result of being your frontline workers?
Who wants Brenda? Jane?
This is Jane at Dayton Children's. We have offered what we call a COVID PTO. If somebody acquires COVID, we allow them a time frame to be off and not have to dip into their normal PTO bank. So that's something we've done. I know that Mickey talked about furlough. We had a very difficult summer with furlough and kept our employees as whole as possible through that process, with having an 80% pay from Dayton Children's through that time frame. So different things based on what we felt we could from a financial component for the organization and being as supportive as possible to the team. As far as the emotional work, again, we don't have as many resources as some organizations. That's where I think we continue to have an opportunity. We have tried our best, to really enhance communication.
And if I could add something else to that, I mean, as healthcare providers, the healthcare that we offer to our employees many times covers a lot of these kinds of things, maybe not on the scale that we're dealing with right now, but we do have programs. I mean, our employee assistance program in particular is being tapped into quite frequently to help with that. And, we're trying to help with helping hands and other services for home. Brenda talked a little bit about daycare. We did tremendous efforts on how to handle daycare. We did tremendous efforts on how to handle help with virtual learning. Our HR divisions just have worked tirelessly to try to find ways to provide assistance for our employees. But our employee assistance programs and our chaplain services are probably our two best assets in our organization to help with what you're asking for here.
Yeah, and Mickey, I do want to thank you for the trigger about employee assistance. In the beginning of COVID, our senior leadership team took a significant pay reduction and donated all of that money to an employee assistance fund. I cannot tell you how valuable that's been, because we have employees that, their spouse or their significant other or their housemate may have lost their position at another organization. So we really have created a robust employee assistance program to really help those day-to-day operations that they have in their homes, to help from a security standpoint.
Brenda, anything you want to say?
I would just add, along the lines of what Jane said, we did something similar. So we had people donate PTO, we had people donate money so that we could support those who were the most challenged during this time. And we would report out how much we were able to help, because that was an encouragement. If you know that you're helping somebody that's a colleague, that helps you to feel better about some of the work that you're doing. And so we have worked, our employee assistance program has counseling available. And so that has been readily available. And our chaplains have just made a significant difference as they have worked with our frontline staff as well.
Thank you.
Okay, so we have another question from Dr. Orlowski. So what is one piece of advice that you would give to an emerging future public health leader?
Can you ask that again? I didn't hear the last part.
Yeah. So this question is from Dr. Orlowski, and there's quite a bit of MPH students on this call tonight. So what is one piece of advice that you would give to an emerging or future public health leader?
I'm sorry. Did you ask for someone specifically, Ed?
No, did not. Go ahead.
Okay. So the one piece of advice that I would give is learn to learn now as a public health or a healthcare administrator, because I think you've probably heard one consistent theme from all of us is that this is about innovation and agility to get through and strong communication and leadership. So you have to practice those, have to learn new techniques all the time. So that would probably be my largest piece of advice. I think the healthcare professionals that I work with, both from a leadership and a scientific standpoint, are most successful when they figure out how to learn enough to pick through what you need to know versus what you don't, and how to ask the right questions and be curious enough with a large enough base that you get it right more than you get it wrong. So if you practice that, when you get into a situation like we're in now, then it comes as second nature to do. So that would be my advice.
I think I would add to that, Mickey, to create a strong network of colleagues. So that goes with the being willing to learn. Throughout this process, as we would come together in incident command, there were multiple times where somebody would say, well, I talked to somebody in this place or this place who was ahead of us, and here's what we learned from them. And so I would say a strong network of colleagues will be critical to help with that learning.
Brenda, thank you. That was Dr. Marietta Orlowski, who is the current chairperson of the Department of Population and Public Health. And I'm sorry Dr. Hart is not on, because I want to make sure he knows that she's a lot more fun to work for than he was. Anyway, he'll laugh at that. So our past chairperson, Dr. Ebert, has a question. When the dust settles, hopefully before 2022, what do you see as policy and operational innovations that will persist post-pandemic?
Well, I'll speak a little bit on that in the lab world, and not to, because I can't on the research side, but the ability for the vendors, the research institutions, the ability of companies to bring products to market that can change a market is incredible. What took a pill, what took a test, what took a vaccination years to bring to market could be done. I'm not going to say weeks. Obviously, you don't want to bring things in haste, but I think what we've all realized is that things don't have to take so long to bring to market, or we don't have to take so long to make a decision on some things. And as Mickey said before, don't let good get in the way of great. Let's move faster on some things. And I think the whole clinical realm of research and bringing products in with vendors is incredible. There's vendors that are using, the BD Veritor is a product we're all using. It's an antigen test, but it was perfected and made for influenza A and B. Well, they just turned it over in a couple weeks and made it one of the top or if not the best antigen test there is. It's the same platform, but it would have taken 3 years for them to do that, to bring that to market. It took them 3 weeks. So, and boy, are we happy they have, because we as a community are using it. So that's been great.
Anybody else?
I think the use of telehealth has been significant through this time. And I think there are many patients who will continue to use that. I think about our snowbirds that go to Florida. They would have in the past had to go find a doctor down there. And this allows them to stay connected with their providers here who know their history and can better support them. So just huge changes in how we deliver care, particularly on the ambulatory side.
Jane, Mickey?
I think in addition to what Brenda and Nick have said, the use of technology to become more of a virtual workforce and be more selective about your in-person time. Also to be able to leverage a remote workforce, I think is going to decrease a tremendous amount of overhead in the healthcare industry that is going to liberate those dollars to be able to be used on less administrative things, as long as we don't get regulated away for putting more in. But I think that the use of technology is going to tremendously be different in the way that we proceed and work in the future, both from a healthcare administration standpoint and from a clinical care and decision-making standpoint.
Yes, I completely agree with Mickey and Brenda's point. We've learned a lot with our time and using technology in a much better way. So I look for many more individuals to have the opportunity to work from home in the future. I think all of us had different individuals working from home, but that group has broadened greatly. So the amount of office real estate that we may need will look differently in the future. And that will ultimately, save healthcare dollars in different ways. So I think we're all looking at anything we can do to be efficient and effective and create the best environment for the patient care team as possible. So I call them COVID wins. Definitely COVID wins. We go through this.
Thank you. Leah's going to read a question from one of our students in a second. Then we'll get back to Joseph's question in the chat box and then go back to Charles Miller. So Leah.
Okay, so this is for Brent.
So I think somebody may have cut out.
It looks like Leah's on mute.
I lost it too.
Leah, you're on mute.
Sorry about that. Can you hear me now?
Yes.
Okay, so this question is for Brenda, and it's from Brandon. What have been the challenges in collaborating with competitors? Do you anticipate future collaborations following COVID?
So that has been the favorite phrase during this pandemic, take yourself off mute. So challenges, I would say our very first call, we all agreed that we would not be competitive through this when we did not even understand what this looked like. And so one of the things that I have appreciated is we have a local hospital organization called GAHA, Greater Dayton Area Hospital Association. And we come together as a community on different topics on a regular basis. Knowing how significant this could be, we all upfront said there will be sensitive information and we are going to do what's right to take care of the community. And I think Mickey mentioned we did tours of each other's incident commands and we have shared data, and it has really been heartwarming to watch how the community was put first. And I would say we would continue those conversations. We still, when we have a question, will either text or call one of our colleagues in one of the other organizations, because we have amazing resources in this community and amazing expertise. We will still all be very competitive, which makes healthcare better for our community. When we're all trying to be the best, it means we're all trying to be better. And so we will continue in that vein, but we will continue the strong collaboration as we go forward.
Anybody else?
I can communicate in the lab world. Remember the picture I painted early on, we had to quickly understand the gravity of the situation, and supplies were thin, hours and such. And we created a lab subcommittee where every week we, as lab leaders from every system in our region, come together, and we just had ours today at 3:30. And we've shared supplies. We've Dayton Children's has helped with testing because of their capabilities. I mean, we have helped each other where when we're in the 9th hour and we need a test quickly, and we can't get to it, somebody who might be 4 miles down the road has helped out, and it's been tremendous. So will we have this lab meeting every week into the years to come? Probably not. But I can tell you just the information sharing, we're all in the same boat mentality, and how can we row together it's been awesome. And I think at the end of the day, if you're an individual who lives in the community, you could go to a Kettering site, you can go to a Dayton Children's site, you can go to a Wayne, Wilson. I mean, it's been impressive, and it's actually helped out a lot, because otherwise, without that knowledge or that information, we wouldn't have it. And somebody probably down the road's already doing it, or somebody down the road has already conquered that thought. So it's been awesome.
Anybody else? Okay. If the panelists would make sure you're in the chat room, I'd like you to read. It's a rather lengthy, it's really a great question. It's probably a full day seminar answer, but that's okay. We'll try it. From Joseph. But while you're reading it, I want to just talk to the question, Joseph, a little bit. And sometimes metaphors work and sometimes they don't. So let's see if it works. I spent 12 years on the American Heart Board here in Dayton. And I was a chairperson for a bunch of years and so on. And we used to sit around at our meetings, our monthly meetings, and we used to lament a little bit about, we work so hard to raise funds for heart disease, but we can't even come close to the funds that are raised just in the local market annually by the Cancer Society. And those of us who were in healthcare would talk about the way to look at it a little bit. I'm not sure if it was right or wrong. But we used to say that to us, being in healthcare, the difference, because we treat both cancer and heart disease, in those two and the impact it has on the families is different. Heart disease, when grandpa, grandma, dad, sometimes mom die pretty quickly of heart disease, the experience of the family in that health issue is finite, it's small. When somebody in the family gets cancer, mom or grandmom or your sister or somebody else, and us guys get it too, is that journey sometimes takes a lot longer and the family experiences it. So we sort of felt that because you can live with somebody and care for somebody and love somebody face to face who's probably going to end up giving in to the cancer issue, whereas somebody who has sudden cardiac arrest at 2 o'clock in the morning, they're gone. It hurts, but the pain, I think, is a little more elongated in cancer. So Joseph, I'm kind of having a soliloquy because I think that part of the answer to your really great question is that in comparison to the issues with food, nutrition, and mental health, COVID is a issue that is impacting the entire population. The issues of infant mortality and food and drug addiction, although significant, don't impact or threaten the entire population at the same time. And it was easy for those who looked to try to find cures for a COVID-19 vaccine to focus like a laser on one solution, as opposed to the multivariant solutions to the wonderful, societal issues that you brought up. So I just kind of did that to give our panelists time to think about their answer. So I'm done.
And I'll start with a comment. We have all talked about how amazing it is in this community with the collaboration. And so I just want to give another example that would relate to a specific population. Before the pandemic, there was an organization created called 115 that was a collaboration between our hospitals to help those with addiction issues. And so it is a great example where we identified a need in the community. And then we said together we can be better than if we do this individually. And so I think our willingness to look at how we make the community we live in a better place will allow us to continue to partner. On the 115 board, there's a member from a professor, and he also sits there with us. And he talks with his students about different projects. And so it's not even just how does healthcare come together, but it's how do we bring together different community agencies that can help us to think innovatively and implement things differently than we have in the past.
Anybody else? Mickey, Nick, Jane?
Yeah, I would like to add just beyond, actually, that was, Brenda, the very first example that came to mind for me too, was that that we already have some areas where we're working together. I think the bigger thing that we need to learn from this particular crisis is to solve a population health challenge. It has a lot to do with the healthcare organizations, but every bit as much it has to do with our community innovators. I mean, Dayton is a foundation of innovation in its history. And, you know, some of our best challenges were solved by bringing in community people to help us solve them. Figuring out how to make gowns in a manufacturing company that didn't make gowns. You know, saved us a tremendous amount of time on PPE for when we were struggling quite a bit to get PPE. And so I think what we need to learn from this is that sometimes the best minds are not just in healthcare today, they're also out in the community. And we need to engage more of our engineers and more of our philanthropists and more of our other innovative people to bring thought to the table that can then get leveraged by healthcare professionals or healthcare scientists to take it to the next level. Creating the way to repurpose our N95 masks with Patel and Patel, that was another great example where an outside industry figured out a way for us to be able to extend the life and so of that equipment and or that resource. And so I think we need to be thinking broader in our population health challenges than just the agencies we go to all the time. That would just be my 2 cents.
Anything to add, Jane?
Get myself off mute. You know, I think that Joe's question's good because we already had problems with all of those things before the pandemic. Pandemic's going to amplify all of those things. So our infrastructure in this community for mental health has gotten so much stronger the last couple years, and it's going to continue to be strengthened with the work that we're all doing together. I think infant mortality is one that we have to be mindful of. We know in this county and we know in this region, we had an opportunity before the pandemic. What we have to do is make sure our moms are getting their well visits during their pregnancy and having the safest delivery possible and not have COVID when they deliver. So, you know, those are all things that we just have to be extremely focused on. I think the other thing that's going to come out of this is what Mickey said. We are known in this region for innovation. You know, whether the innovation is, you know, Dayton Children's is going to have counselors that are resilient in the future and now. those individuals are, I hope, going to help our Dayton Public School students in a way that prevents them from having some of the mental health issues in the future. So I think innovation is going to be core and being really creative, but this is going to take all of us working together, and it's not going to be a quick fix because these were all problems before the pandemic. And Joseph, you're right. It's going to get worse with the economics of what impact the pandemic's had on each and every individual.
And Joseph, getting back to a solution, your comment about complex and daunting, I think that the journey that healthcare facilities were on from March until today in learning how to treat COVID patients and protect staff and visitors and so on was the complex and daunting thing. But in my opinion, the fact that we can have a single solution at the other end, which is a vaccine, is something that's not a single solution for the other societal issues you brought up. So I think that those issues will continue to be complex and daunting. Dr. Hardy, you're back on. Is that correct? We thought we had him back. Okay.
Hey, Ed, real quick, just one quick point. You know, public health. You know, I've worked in healthcare a long time, and I really truly didn't know what the public health department did on so many different things. And I think a lot of topics we just talked about really is showing what a well-run, a well-strategized, a well-funded, a well-organized public health department is. And, you know, with Jeff and Mickey and such at the Montgomery County Public Health, we've worked with them a lot. And, you know, they have not slept either, but I've learned so much from public health and what they do to a given population in coordination with the health system. So it's, in my eyes, it's been very impressive, but I've also learned a lot from the public health departments, if you will.
Nick, that's a great point. I'm going to speak a little bit for Dr. Ebert, if he'll let me, but in the 10 years I've been doing this program, there's a large number of our graduates, MPH students, who are out there in the 8 or 9 counties around here, and they're some of the best and brightest. And I know there's a whole bunch of them that went through the program before I got here 10 years ago and into the program. So I know the talent that's out in our public health departments, and you're right, they're working tirelessly like you are as well. We've got time for one more question if somebody's got one, or I can begin to wrap it up because we've had our panelists who got daytime jobs too and are probably still on call, giving us extra time. Anybody got one more question? Okay. First and foremost, again, I want to thank the 60 or so people that dialed in, but I want to really thank the 5 panelists. As I mentioned, I've worked with all 5 of these fantastic professionals, and I know how seriously they take these programs and how much thought they would put into it. So I know it's hard to give them a round of applause, but I'd like to have you give a virtual round of applause to our panelists and thank them very much. Okay, as I wrap it up, I'm really going to talk to the students in the course for a second. And I hope I reported this correctly, but basically what I think what you witnessed tonight and heard was you heard a lot of tactical operational leadership in action. And I think Nick's the one that used the word innovation. And although the title of our course is strategic leadership, I think what happens is sometimes tactical innovations and quick decision making you have to make on the fly that you later hardwire in a policy is what makes your long range strategic process better. So I think you heard some fantastic people tonight. Thank you all for dialing in, and to the panelists, your check will be in the mail. Any last thoughts from panelists? Dr. Ebert, if you're still out there, as I do at each class, I always give you the last word. Dr. Ebert? Well, in the absence of Dr. Ebert, we'll ask Dr. Orlowski if she's still on, if she wants to make any parting comments as the chairperson of our program.
I am just amazed with this panel. I thank you all for sharing your expertise and your wisdom. I think my favorite quote for the night, just being a lifelong educator, is learn to learn. And so thank you all. We really do appreciate being part of the community with you. So thank you.
Well, that's the end of our program. Happy holidays. Stay safe. Wear your masks. Was it masks up, cell phones down, and wash your hands? How's that? Good night. Thank you. Thanks, Mickey. Mickey applauded all of you.
Dr. Ebert's here, but maybe it's not working.
Pardon?
Dr. Ebert isn't here, but I don't think his mic is working.
Okay. Are Brandon Phasing still on?
No. No.
Tazine is on.
Yeah, that's someone else.
What?
That's someone else.
She was a graduate assistant, or one of our students.